So in couple of next minute, I am going to talk about the patient-related complications and management. I think you all are aware about the depth of the ECMO indications, initiations, initial management, how to manage a patient for a few days to weeks. And now I'll be talking about the complications. Okay. I have nothing to disclose and no financial sponsors. So objective of my talk. Yes. Okay. So objective of my talk will be about the introductions of the complications. What are the incidents of the complications which we are going to come across? Different type of complications. So as we all are aware, it is a mechanical complications and patient related to complications. But I am not going to cover the mechanical complications. I am going to cover only a patient related complications. What are the important steps or the important measures to be taken to avoid all these complications? What are the management if we'll come across the complications which I'm going to discuss? And definitely it is always better, prevention is always better than cure. So we'll like to avoid prevent these complications. Okay. As we all know, the ECMO is not a easy task. It is a blend of men and machines. So whosoever is he or she requiring a ECMO support already on so many gadgets in your ICU, it is a sickest patient of our ICU. And on top of it, we are going to add a more complicated system to it. It is an extracorporeal therapy. So we have to take care, or we have to take care more extra cautiously, or make a balance between machines and men, and then only we will able to win such patient successfully. So incidence, this is the latest slide I am going to share with you all, has been reported in May 2024 by ELSO. As we all know, it is an patent sites. So ECMO come under the auspices of ELSO. So they had collected data from 2019 to 2023. And I'm going to discuss here about the adult respiratory complications only. They had divided this all group of patients in three subcategories: adult, pediatric, and the neonate, and then the VV ECMO and the VE ECMO. So respiratory ECMO or a cardiac ECMO. So today I'm going to share only a slide of adult respiratory complications incidence, and according to that we'll adjust the what are the incidents we come across and the complications we'll come across. So if you see the initial slide, they had mentions about the mechanical complications, which I'm not going to cover today. What I'm going to discuss today is only a how can I go back? Yes, here. In the lower the slide, you can see the hemorrhagic complications. So this is the commonest complications which we come across during our ECMO runs. And majority of time it is vary from 10 to 20-25%. Next come, if we see the incidence wise, next come the renal and the neurological complications, and there are separate talk regarding the neurological and renal replacement therapy which we use routine over the ECMO patients. So I'm not going to discuss in details about the neurological and the renal complications, but definitely we'll discuss in detail about the type specific complications and the hemorrhagic complications. Next, there are different type. I already discussed mechanical complications like pump failure, power failure, oxygenator failure, air in the circuits, or the thrombus in the circuits, or the thrombus in the pump or the oxygenator, which I'm not going to cover. That we'll discuss when you come at Bombay in a hands-on practice. We'll come across it. But here I'm going to discuss about the patient-related complications. Second type will depends on the which type of ECMO are we going to use. So are we using the VV or the VE ECMO, because there are specific complications which we come across while VV ECMO is a recirculations and right heart failure. In VA ECMO, generally we come across is a north-south syndrome, which we call nowadays as a differential hypoxia, limb ischemia, and Elvis turning. The third component is third part is the component use which you are going to use. Here I am not promoting any of the machines or the companies for it, but as a ECMO physicians, we should know there are different companies which are making the ECMO machines. So some of the companies like Medtronic, if we use a Medtronic pump, their half-life of the Medtronic pump will be a 7 days, because it is a barrel race pump. So because of the bearings there, it is heated fastly and there are more chances of hemolysis. So if you use a Medtronic pumps, there are chances of hemolysis is going to be more, and frequently you will require to change the pump. In other hand, if you use a centrimac machines, it is a bearing leg pumps. So and the priming volume is very less, so it can be used for more of the days. But here again, important point is we should use judiciously. Suppose if you are planning to use a ECMO as an ELE ECMO for the shorter period, in that case is if you use a centrimac pump, because here we are considering as a cost also, because India is in a economy constraints. So for the shorter durations of run, definitely I will prefer a Medtronic pump. And for the longer runs like VV ECMO, COVID ARDS or the H1N1 ARDS, centrimac pump would be the better. So whenever you are planning to initiate or starting a ECMO program, these all short things, but keep in the minds when we are planning for the buying a new machines in our institute. So to details patient related complications is, first is we will divide it in a system wise. So hemorrhagic, so generally we come across is a cannula site bleeding, surgical site bleeding, or a diffuse bleeding from all the cannula sites, or the catheter site bleeding is there. So systemic bleeding, systemic cause would be there. Second is hematological complications like DIC or hemolysis, because we all know there are components from where the blood is passing through. So there are chances of hemolysis if we run with the high flow supports. Neurological complications like CNS infection, seizure, brain death, CNS hemorrhage, which we are going to come across, but not routinely seen neurological complications with the pediatric and neonatal. It is more common with the adult cases. Cardiovascular problems like tamponade because of this blood surrounding the heart covers, myocardial stunning, hypertensions or hypotensions, arrhythmias, which we come across, and the pulmonary complications like pneumothorax and the pulmonary hemorrhage. So now we'll discuss each one by one in detail. So the hemorrhage first we'll discuss, which is the commonest complications which we come across while the ECMO runs. And the incidence of hemorrhage we see somewhere around 20 to 30% of range. Of course, it is a second most cause of death during our ECMO runs. So hemorrhage is a dead complications. Try to avoid is most commonly seen with the cardiac crisis as compared to respiratory, because here the arterial puncture is there. Second, the ACT requirement, as we all know, Dr. Ojha sir recently discussed, we keep ACT target high in the cardiac cases and we keep ACT target low in the respiratory cases. Hemorrhages are more seen with the adults than the neonates. Causes, it is very important questions, because whenever we run a ECMO program or institute and somebody identify the hemorrhage, our first blame is on the heparin. But here I want to highlight that heparin is not a culprit for your hemorrhage. Yes, of course, it is an affectionate factor with another causes. So don't try to blame all the times with the heparin because the patient is on heparin, that's why they are bleeding much. No, that is not the case. So all the time we doesn't require heparin to be stopped, but of course whenever the patient is on heparin and it is a longer run, we have to adjust our ACT targets, and sometimes we have to cut down our heparin requirement. In certain cases like a profuse bleeding is there, patient is hypotensive, tachycardic, and it is a systemic bleeding, where we sometimes we run a heparin free ECMO also. Site, it could be a local site like cannula site bleeding, it is very easy to manage. And very important, from the causes, it starts from your puncture sites. So whenever you do a cannulations, be very meticulous. You can use a sono sites also, because blind punctures, if you do a arterial puncture by doing a VV ECMO runs, and later on you put a patient on heparin, or sometimes you require a boluses also, then your arterial puncture can cause a hemorrhage from the cannula sites. Second could be the cause, simplest, your RT aspirations, because sometimes our staff nurse doing aspirations with the 50 ml of syringe, and patient is vulnerable, already sick patients. So if you aspirate from the RT with the 50 cc of syringe, there will be a chance of ulcer in the stomachs. And if you give such patients with the heparin and your loading dose, then there are chances of bleeding. Third might be your repeated suctioning. So always we prefer blind suctions catheters while we put a patient on ECMO, so there are less chances of trauma in the upper airway. Because if there is a persistent trauma in the upper airway, and if again the patient is on heparin, there are high chances of bleed from the tracheostomy side or from the upper airway. So these are the small points, but we have to take care. If we'll take care of these small points, then the hemorrhagic complications will be a very less. Consequences of hemorrhage, we all know, there will be a tachycardia, hypotensions. If there is a bleed inside the GI tract, patients may start spurious diarrhea also. If there is a bleed from the tracheal sites, then there will be a signs of hypoxia. If there is a bleed, if there is an intracranial bleed, patients will become unconscious, or there are chances of seizures also. So we have to identify the site, and depending on that, we have to take our management steps. So this is the hemorrhagic parts. What are the general measures whenever you come across of the hemorrhages during our ECMO run is? So first, decrease the ACT target. Suppose of initiations, if your ACT target was 160 or 180, cut down the ACT targets. Don't try to stop heparin in all the times. But whenever we cut down the heparin dosage, or will cut down the targets of ACT, always there are chances of clotting inside the circuit. So to avoid one complications, you will end up with the another complications. So to avoid such complications, always whenever you decrease the target of ACT, increase the ECMO flow, because once you increase the ECMO flow, then there are less chances of clotting inside the circuit and any component of it. And whenever we cut down the heparin, or we stop the heparin doses, be ready with the new circuit and entire sometimes components, or sometimes you require entire circuit to be changed. So you have to be prepared and mindful for it. Always ask for the details coagulations cascade analysis. Don't rely only on ACT or PTT. You should ask for the complete coagulations cascade like PT, APTT, fibrinogens, complete hemograms. And if your institute permits, you can ask for the TAG and ROTEM, because there are very good guides. You can always ask for the plasma-free hemoglobin, LDH, bilirubins, and TAG and ROTEM will give you a guide of optimizations of clotting parameters, and depending on that, you should strategize your transfusions therapy, because it is not an easy task to transfuse all the components together, because as yesterday we had discussed blood transfusion strategy. Whenever we transfuse such component like platelet, the heparin requirement goes high. Here the scenario is different. We are going to transfuse platelet, we are going to transfuse FAP, and we are running ECMO with the low target of ACT or the low dosage of heparin, then there are chances of the clotting inside the circuit. So be aware of it. So try to avoid clotting complications while doing a measurement or treating complications like a hemorrhage. In this case, you always try to root cause analysis, try to find out the sepsis. And if you find a particular area, suppose if there is a alveolar hemorrhage, there are different strategy for it. You can use a APRV mode, you can use a bilevel mode, as recently Dr. Oja sir mentions, give high PEEP, you can do a bronchoscopy bedside, all sorts of procedure. There are not contraindications, but try to minimize of any surgical procedures whenever you find out the hemorrhagic complications, because if you do a procedures before doing the procedure without complete coagulations cascade, there are chances of another complications. So you can do a bronchoscopy for GI bleed, you can do even upper GI scopy, lower GI scopies also. You can use a proton pantoprazole infusion, somatostatins, octreotide you can use. For IC bleed, if it is a grade 1 or 2, can manage conservatively, do a CT scan, EEG bedside, nurse monitoring, or the TCD can give you a good guide also. So these are the options depending on the site of your hemorrhage. So you can stratify the site of hemorrhage, and depending on the site and size, you can take a measures accordingly. Factor 7, of course, it is not absolute contraindications. You can use NOVA 7s also, but use very judiciously as a last resort. But if you use a NOVA 7s, be prepared with the new prime circuit on the bedsides, because eventually it will clot the old circuit, and already it is an old circuit. There are small clot who are going to be there inside the component, like at the pump head or in the oxygenators. So it is always be prepared for the next consequences of your complications. If it is a local site bleed, you can give a compression over the cannula site. If it is a tracheostomy site bleed, you can use a cauterize for the local sites, or you can apply the adrenaline goes over it. So these are the small steps, but very important while you come across for the hemorrhagic complications. Next is hemolysis. Of course, again, it is the second most complications. Incidence for adult are around 8%. For the pediatric, it's slightly on the higher side. It is around an 80%. So why the hemolysis occur? Because we all know it is a centrifugal pumps. So it will work like an peripheral art. It sucks the blood, and they'll be causing a negative pressures on it. So if your tank is empty and if you are running with the high pump of speed, then there are chances of, because of the shearing force, it causes the hemolysis. Second is repeated chatterings. If you are don't if you are encountering repeated chatterings inside the circuit, and if you don't do a root cause analysis, it's also causing a cavitations inside your cannula or inside your circuit. So there are chances of hemolysis and there are chances of air inside the circuits. So you have to be careful about it. If there is micro clots inside your three ways or the pressure lines inside your oxygenators, these are also cause hemolysis. High heater cooler unit temperature, that is again a cause. If you use a smaller size of cannula, so because of the smaller size cannula, it's require more force and RBC distractions will be there. Again, this will be causing a hemolysis. So these are different causes you have to identify with and you have to treat accordingly. So we can diagnose a hemolysis during our ECMO, and it is easy, same we use in our routine ICU measures. If you take a samples inside the vacuity and if you see the red serum noted here, I had mentioned it, that is the first signs of hemolysis. Second, again, a bedside measures. If your urine color has been changed, it was yellow, now it will become a darker urine color, that again will give you a good guide and will tell you about the hemolysis. High LDH level, high retic count, unconjugated hyperbilirubinemia, that's again will tell you for the hemolysis. And very important markers is plasma free hemoglobin. The normal value of plasma free hemoglobin is around 5 milligram per deciliter. If it is more than 10 milligram per deciliters, that is the indication signs of a hemolysis. Despite of that, if there is a no red color urine or the color change in the urine, that will give you a good guide. And whenever you come across the high plasma free hemoglobin level more than 50, that is an indication to change an entire circuit. If you are not able to identify the clot inside the circuit, but the high plasma free hemoglobin level more than 50, that means there is a clot inside your oxygenator or a pump, and you will get an emergency, and there will be a flow low, and there will be, even there is a no flow change inside your circuits with the same RPM. If you are getting good flow but your plasma free hemoglobin is more than 50, that is an indication for the change of your circuit. Treatment again remain the same, which we do routinely in our ICU, is force alkaline diuresis and treat the underlying cause. Before going into a next complications, it will be a type dependent complications. Before that, I would to highlight on these 4 points. It has already discussed yesterday while we were discussing about the physiology of a ECMO, but it is very important. If you're not able to understand this terminology, then it is going to be difficult to understand the further complications, type related complications. So patients, any patients on extracorporeal therapy has a dual circulations. Dual circulations means patients on native circulations and extracorporeal circulations, which include even for RRT also and for ECMO also. Any extracorporeal circulations, it is a non-pulsatile flow. So our native flow is pulsatile flow. So we see a difference of systole and diastole and we get a pulse pressures. In ECMO flow, it is a non-pulsatile flow, continuous flow. So there will be no systole, no diastoles. Third terminology, net circulations. Again, net circulations means a mixture of a native circulations and ECMO circulations, extracorporeal circulations. So where the native circulations will take place, again, will depend on 2 things. One, which type of ECMO are we going to use, and cannulation strategy. For adults, generally we use in VV ECMO is femorojugular strategy of VV ECMO configurations. There the net circulations will take place in the RA. So in RA, there will be oxygenated blood coming through your return cannula, and from the pulmonary vasculature, there will be a native circulation. So the net circulations for VV ECMO in adults, generally it is a right atrium. And net circulation, generally for VV ECMO, we use a term of mixing cloud. So what is a mixing cloud? Again, it is a mixing of native circulations and of your extracorporeal circulations. So in VA ECMO, the mixing cloud occurs generally in the arch of aorta. So if we understand this terminology, then it will be easier for us to understand the next type related complications. So first we'll discuss the VV configurations. Generally in adults or in the pediatric age group, we use a femorojugular configurations. For the neonate, if it is a less than 20 kg or less than 15 kg of child, we can't cannulate through the femoral cannula because it is not properly grown up. In that cases, we have to no choice, but we have to do under VA ECMO. So as far as the pediatric and the adult ECMO concerns, generally we use a femorojugular configurations for our VV ECMO runs. So what happen in these configurations? The blood will be sucked through the centrifugal pump from your femoral side, whether it is a left side or right side. The blood will be sucked using a centrifugal pump, and it will enter into your oxygenator. And from the oxygenators, oxygenated blood will enter in the right atrium via your right IJV, so your return cannula. If you use a reverse, so if you use as an jugular as a drainage cannula and femoral as a returns, again the maximum mixing point occur at this juncture. And if you use a femoro-femoral, because in some cases we are not able to cannulate the jugular cannula, then always be mindful where the cannula's tip lies. So your drainage cannula will lies has to be somewhere into the renal vein, near to the renal vein. So you will drain your drainage cannula's tip will lie into the renal vein sites, and a return cannula has to be lie at the hepatic IVC and the RA junctions. So the important point here is at least we keep to maintain 10 centimeter of distance between the two cannula, between the drainage and the return cannula. If it is not, we are not able to maintain that, then there are chances of a recirculation. So what is the recirculations? So as already discussed in routine scenario, the mixture occur at the RA. So here, but what happens when both the cannula come closer, or if you run a VV ECMO with the high speed, with the high flow, then there are chances of whatever occidental blood which will enter into your RA will suck by your drainage cannula without entering your systemic circulations. That is a phenomenon which we call as the recirculations. Is it clear? So again, I am repeating you, the blood flow, oxygenated blood which are coming from your return cannula to the RA, it's sucked by your drainage cannula without entering to your natural circulations. So that is a phenomena which we call it the recirculations. So in details about the recirculations is, what are the factors which affect the recirculations? So first, I had already explained, if your ECMO speed, if your pump speed is very high. So if you are running VV ECMO with the high speed of pump and the flow is very high, then there is a high chance, because it's creating a negative pressures over the RA. So it is there are chances of recirculation. Second is cannula positions. If your drainage and return cannula are closer, then there are chances of recirculations. Cardiac output. If your cardiac output is very good, then your blood flow is very fast, then there are less chances of recirculations. But when the cardiac output is very good, but patient it become arrhythmic, suppose arrhythmias like sinus tachycardia or the atrial fibrillations with the high ventricular rate, where your tricuspid valve will not get adequate time to open it up. So in that cases also there are chances of recirculations. And third thing is RA size. That means your tank is empty, patient is hypovolemic, it is sucking too much from your RA and RV. So these are the 4 factors which affect your recirculations. So how we can identify on the clinical sides of the recirculations is, if you see the progressive gradually decline on SpO2. Suppose if your patient was maintaining to start with saturations of 95 and gradually the SpO2 is coming down up to 85, 86 with the same RPM at the same flow, then there is a first signs of recirculations. Second, how we'll identify? If you check the pre-membrane ABG, and pre-membrane ABG, if your PO2 level comes around 85, that is the second indicators of which tell you about the recirculations. Third thing is, if you increase, because what happened, as Dr. Oja sir mentioned, everything is flow in the VV ECMO. So whenever we notice there is a hypoxemia, and what is our first action is increase the flow. So what we'll do, we'll increase the pump speed, we'll increase the flow. But if there is, despite of increasing the flow, if your saturation is not improving, that is a third signs the patient is getting a recirculations here. And the last bright red color of both the cannula, that is a definitive signs of the recirculations, but it is in the late stage. If recirculations occur in the initial stage, both cannula color will be not bright red. So first step, there'll be a mild hypoxia. So we have to be very careful about it. So always there is a certain amount of recirculations which will be allowed, and it is going to be there in the VV ECMO runs. So up to a 30% of a recirculations, which is acceptable. More than 30%, it is not acceptable. Then your patients will becoming a hypoxic. So SpO2 level will goes down. Okay. So that is a very important slide here is that will tell you about the recirculations and the plumb flow. So the recirculations fractions is increasing linearly with if you increasing a pump flow. So if you increasing the plumb flow, same time there are chances of a recirculations. If we compare here in the graphs, if you increase gradually your pump flow, the effective flow gradually increases, so simultaneously increasing up to a certain extent. So at that point of your time, if you increase the pump flow, your effective flow will not increase, it will become a stagnant here. Okay, so steadily rising a pump flow, effective flow will improve, but up to a certain level, when you increase the pump flow, your effective flow will be the stagnant. And despite of that, if you increase the pump flow, you can see the ratio effective flow will goes down. So always you have to be careful with the ratio of RPM and flow. So whenever you run a ECMO, always check for the ratio of your RPM versus flow. That will give you a good guide of your recirculations. Okay. Next is there is a formula for recirculations which we all use in our routine ECMO runs. So for that you will require 3 ABGs. One for SVO2, we will take ABG from the central line. For the pre-oxygenator SO2 is we take a pre-membrane ABG, and for the post-membrane we take ABG from the post-membrane. So while we are making the circuits, there will be a 3-way from where we can take a samples also. This is not routinely used. Only when you suspect recirculations or we suspect oxygenator failure, then only we'll take a samples from that. Otherwise, routinely we take a sample from the central line or the arterial line. Okay. So if you do 3 ABG runs, there is a formula will give you the recirculations calculations. So again, I am repeating you, up to a 30% recirculations is accepted. More than that, it is not expected. Okay. So how will you manage? How to diagnose it? Of course, the tube color, persistent hypoxia. If you do a serial X-ray, and in X-ray, if you see both the cannulas are coming closer, there will be a good guide. Again, you can do a T. Again, we'll tell you about the closure of the cannula. So how we diagnose the recirculations and how to manage it. So if you gradually, if you decrease the flow of ECMO and if your saturations improves, then that means there is a definitely recirculation. Just stop it. Don't increase the flow after that. So that means if you get adequate SpO2, don't increase flow. That is the first management. Second, despite of decreasing flow, if your SpO2 is not coming up, that means the flow is not a culprit. That means the culprit is your cannula positions. In that circumstances, you have to repositions or your cannula. So always don't try to pull all the cannulas to start with. First, adjust the bed sides. So give a head up positions or give a head low positions, give slightly a turning, give a compressions over the neck. If giving these simple measures will correct the hypoxia, then your cannula repositions has been done. Despite of that, if you are not able to maintain the SpO2, then only you do a repositions of cannula, because repositioning cannula will require to resuturing, open the previous sutures. Already there might chances of the hemorrhage on their sides. So don't jump always to repositions cannula. Give a pressures, give the head up positions or head low positions. And despite of that, if you are not able to maintain, then only do a repositions of cannula. Treat the underlying cause. I already mentioned if there is a tachycardia or AF with fast VR, if you treat it, if there is a persistent chattering, patient is hypovolemic, these are the simple measures which will tell you or correct your recirculations. And the last options, despite of doing all these measures, still the patient is hypoxic, then there are no other options than adding another drainage cannula, because drainage is not sufficient with the single cannula. You might have used a smaller size of cannula in those cases. So in here, it will be a variants of ECMO, not a hybrid ECMO, because the configurations was VV. Now we are adding another drainage cannula. So the next configurations will be VV-V. So the drainage will be the dual drainage. So if the previous configurations was the femorojugular, then you insert another drainage cannula from the opposite side of femoral side. But be careful, if your previous cannula, which was as a drainage cannula, was lying into your hepatic IVC, the another drainage cannula which we are going to introduce to the patients will be lying somewhere at your renal veins. So positioning is very important. So the first is use a variants of ECMO. Despite of that, if you are not able to maintain it, then there are no choice and you have to convert it from VV to a hybrid ECMO. So from VV configurations, it becomes true, your IJV and the femoral become your drainage. and using a Y connectors, and you have to take another femoral artery as a returns. So this is then last options, but not routinely, since if you do a routine measures, you will correct your recirculations. So this is all about the recirculations. Next, complications of your VV ECMO. There is very important slide. Can you see the color difference between two cannula? First is your drainage cannula, and the second number label is your return cannula. So in first slide, in first picture, you see there is a difference of colors. That is a properly placed without recirculations, proper oxygenation is going on. The third slide here, you see both cannulas are bright reds. So that is again, the diagnosis is confirmed, nothing than the recirculations. But what if you see both cannula color as a drainage, as a returns, both become a not dark color, not a bright red color. So what does it indicate? It's indicate both the cannulas are dark color. That means that is an oxygenator failure. So you have to check for your connectors on the bedsides where you connect the oxygen connectors are loosen up, or on the blenders where we connect tubings is also not tighten up. And the third thing could be a least but not is your oxygenator failure. So these are the three diagnoses you can come across when you see the both cannula colors are the dark. Okay. Next complications which we come across for your VV ECMO run is a right side failure. So what are the factors which are going to affect of your right heart failure is, so always we recommended to do and the echo prior to start your VV ECMO runs, because if already right sided heart failure is there, that is an absolute contraindications for your VV ECMO runs. So already if you see their pulmonary pressures are high, if it is a mild, that is okay, but if it is moderate to severe, it is an absolute contraindications for your VV ECMO runs. So if you during your VV, and if it was not there in, if you had initiated VV ECMO run, generally right heart failure, it's mimic like an sepsis, and it is seen in at the end of third week or the fourth week. In fact, in our initial days, I remember in 2015, 2016, when we were doing only VV ECMO runs, at the later stage, we were all the times we were considering it is an sepsis. But during COVID times, when we did a repeated echo, because during COVID time, there was a longer duration ECMO runs, and then only we encountered it is not a sepsis, it is because of the right heart failure. So why the right heart failure occurs in the long run VV ECMO runs? Because I had already mentioned, as the configurations, you are getting constant flow on the RA. So native circulations is there, on top of it, a 4 liter or 5 liter flow is coming over the RA. So over the period of time, for the longer run, your RA become a distended. And because of the RA dysfunctions or RV dysfunctions will be there. So over the period of time, over distensions of RV, it is not, if you are not unloading your RV, again from the RV, it becomes the left-sided failure and it is a mesh. Okay. Second factor is your persistent consolidations. If your lungs are not recovering, if you see persistent shadows on your chest x-rays, that is also causing a right heart failure. Prolonged hypoxia, because hypoxia also causes a pulmonary hypertensions. So these are the main three factors if you run with the high flow, which are causing the RA failure, and at the end of it is causing the right heart failure also. Prolonged hypoxia, persistent consolidations, these are the factors which causing the right heart failure during your prolonged ECMO run. Mind it is not routinely seen in the initial days or the first or second week. It has been seen only at the third week or the fourth week. So always do every weekly or every 10 days echo if you are not able to win such patients. So sometimes your heart is lungs are okay, but you are not able to win such patient, that the cause could be because of the right heart failure. So a beautiful diagram recently in one of the journals, I had picked up this. So persistent RA overload will convert into the RV overload, and because of the RV overload, there will be a ventricular septal displacement. So the movement will be not proper, and LV is also getting a filling, more filling. So because of the over distensions of the RV, LV dysfunction secondary occurs, and your cardiac output will be decreases. So these are the factors from which you are not able to win a patient from your VV ECMOs. So how we can manage the RV dysfunctions during our VV ECMO runs? First, what are the consequences of the RV dysfunctions? Is there will be a hypotension, there will be a tachycardia, congestive liver, congestive hearts, and the congestive brains will be there, low urine output, renal failure, high lactate levels. So it mimics like an sepsis. But if you do a Scout's culture, ET secretions, there will be no signs of sepsis. Your PCT, WBCs are fine. So then you have to do an echo where you will see a TAPC is less than 14 and right heart pressures are very high. That is a diagnosis of RV dysfunction. So how we will manage it? Initially, we will add of inotropic support. So we'll start with the noradrenaline to increase the blood pressures. Once we see the perfusion pressures we are achieved, then the second step we add the inodilators like milrinones or the dobutamines, which will help you in the decreasing the RV loads. If you get a chance, you can use a fluid challenge also. Once your hemodynamics has been improved, there is a good guide. Use a diuretics, digoxins, calcium channel blocker, but it helps only in the mild to moderate RV dysfunctions. If it is a severe RV dysfunctions, or diuretics, CCB, digoxins will not work. And treat the underlying causes. Suppose your lungs are not improving, there is a persistent stedo in the lungs. Try to find out the cause. Do the recruitment maneuvers, increase the ventilatory settings, mild to moderates. So these are the plan which we kept in mind when we come across of the RV dysfunctions. Of course, when there is a, I had already told there is a persistent hypoxia was also causing the RV dysfunctions. In that cases, we have to increase the ECMO flow to improve the hypoxia. If you improve the hypoxia, mild to moderate RV dysfunctions is also going to improve. Generally, we use inhaled nitric oxide specifically for the children's or the neonates age group, and adults also we can use the inhaled nitric oxide, sildenafil. These are the options for the moderate to severe RV dysfunctions. And all this medical management doesn't work, then only no options. From VV, you have to convert into the hybrid ECMO. So you have to convert from V to V-VA. So it become your hybrid ECMO. And there will be a drainage cannula from your femoral sides. And return will be the IJV and the femoral artery. So use again the Y connectors. But whenever you modified the configurations, always remember your heparin requirement will be goes high and your ACT target has to be kept very high. Otherwise, to treat underlying cause, you will end up with the clotting inside the circuits, because there will be a Y connector. So there will be a more shearing force. There are more chances of hemolysis and there are chances of clotting insides also. Always use a high dosage of heparin. Nowadays, Protect Dio cannula is available, from where we can use a drainage from the right atrium and put another distal cannula in the pulmonary artery. Of course, I have never used the VPA ECMO, but yes, theoretically it is available there. So you can use a Protect Dio cannula. So from using a Protect Dio cannula, your RA will be your drainage and pulmonary artery will be your return. So you can avoid the overload over the RV. So these are the points in the management of RV dysfunctions. Now we are moving towards the VA ECMO complications. As Dr. Ojha sir recently mentions, the complications of VA ECMO are more difficult to treat, but of course we have to treat it. We have no options. So already I had discussed about the mixing clouds, which we come across during our VA ECMO runs. So this is very beautiful slides which explain you about the differential hypoxia. So another name of differential hypoxia is your Harlequin syndromes or the North-South syndrome. Previously, we were using these two terms, but nowadays also recommended to use a differential hypoxemia as a diagnosis. Okay, so whenever you start your VA ECMO runs and your pulse pressures are very low, your cardiac are standstill, so hardly cardiac is pushing something towards the arch of aorta. In those circumstances, the complete circulations will take place from your ECMO side. So there will be a less retrograde circulations. Always there will be antegrade circulations from the descending aorta. So your native heart, your coronary, all branches of your arch will get oxygenated blood from the ECMO supports. Now the scenario difference. While put a patients on ECMO runs, gradually your LV start improving. So what will happen? Cardiac started, your LV started ejecting some things. Your pulse pressure are somewhere around 10. So native circulation started slightly better. So in that cases, your coronaries and initial part of your arch will get oxygenated blood from your native circulations, and rates of your arch and the branches of the arch will get oxygenated blood from the ECMO flow. In late stage, at the third day of your VA ECMO run, again your LV start improving, pulse pressure become more widen up. So what will happen? Heart started, LV started pushing more blood towards the arch of aorta. So right side of your branch, first right brachiocephalic branch on your coronaries will get oxygenated blood from the native circulations, and distal branch of your arch of aorta and the descending arch will get oxygenated blood from your ECMO circulations. Now your LV is improved somewhere around 40% and ejecting more blood. So all branches, including your 3 branches of your arch of aorta and coronary, will get oxygenated blood from the native circulations, and the distal part of your descending aorta will get a oxygenated blood from your ECMO sites. But if scenario differs, your lungs are not improving, but your heart is improving. So what will happen at this stage? Your heart is improving, but your lungs are deteriorating because of the previously LV dysfunctions. Now the LV is flooded with the volumes. So in that cases, a native circulations is hypoxic blood and ECMO circulations is a more oxygenated blood. So right side of your body will get, and the upper part of the, initially the right side upper limb. So always we prefer to put a arterial line on the right upper limb and monitor SpO2 on the right fingers only. So that is a good guide to diagnose of a differential hypoxemia. So when this we come across only when if your heart is improving but lungs are deteriorating. If both organs are improving, will not come across these complications like a differential hypoxemia. Only we come across when your heart is improved but your lungs are not improving. So the portions of arch of aorta which is getting a oxygenated blood from the native flow, but lungs are not good, so it is not getting proper oxygenated blood from the native circulations. So upper part of your body will become hypoxic, and the lower part of your body will get a good oxygenated blood from the ECMO supports. That is a terminology will cause as a differential hypoxia. So I think it is clear about the differential hypoxia. How to treat it? So first, decrease the native circulations. Okay, because I had already spoken, because we are increasing the ECMO flow, so decrease the native circulations. How will decrease the native circulations? So decrease the inotropic support. If you decrease the inotropic support, what will happen? There will be low pulse pressures. Again, there will be not good help in decreasing the native circulation. That is not a good choice to decrease the native circulations. Next is increase the ECMO flow. If you increase the ECMO flow, again the story will remain the same. So this is not a good option. But very important point here is improve a native oxygenation. So how will you improve the native oxygenation? I had already explained lungs are weak. So you improve your ventilatory strategy. So instead of a rest ventilatory setting, made it a moderate ventilatory setting, increase some amount of PEEP, increase the respiratory rate, increase FiO2 on ventilatory settings. So if you increase the native oxygenations, so the coronary and the arch of aorta and the right side of your body will get a good oxygenated blood from the native circulations. It will improve the differential hypoxemia. If that is not the case, then there again there is no options. We have to add in the VA configurations, we have to add another return cannula, not a drainage, a return cannula. So previously it was the VA configurations, now it become a V-AV. So use a Y connector, drainage will be from the femoral vein and return will be in the femoral artery and opposite side of femoral vein. Again, increase the heparin requirement, your ACT target will be high. It is theoretically, it is easy to discuss the hybrid ECMO, but definitely it is not so easy practically. Okay, so that aspect, practical aspect we will discuss when you all come at the Riddhi Vinayak. And change the cannulation strategy. Yes, very important point. So we come across these situations only when we use a femoral cannulations. If you use the axillary cannulations or the subclavian cannulations, of course, it is not an easy task. You require surgical backup. You require even a CVTS or the vascular surgeon backup for it. But yes, that is an option. If you use axillary cannulations or the subclavian cannulations, but be very careful whenever you do a subclavian or a axillary cannulations is the tip of your cannula should lie at the arch of aorta, because if it displaced towards the descending arch of the aorta, what will happen? There will be more force over the aortic valves and it will damage your aortic valves, so you will end up with another complications. Okay, so be very careful while you choose a axillary or the subclavian artery cannulations. Next complications which we come across during our VA ECMO run is limb ischemia. Already we had discussed thromboembolic phenomena are very common in VV ECMO runs. And why it is occur? Because if you put a larger size of arterial cannulations, the dictum is you should cannulate somewhere around 80% of your native cannula, native vessel size. Because if you use a snugly fit cannula, what will happen? It will hamper the distal perfusion. So always use the smaller size cannula. So it will give you a guide using the ultrasonograph while doing a cannulations, will tell you about the diameter of your vessels, and use a smaller size cannula while putting it. And don't forget to put a distal perfusion cannula. And sometimes if you have inserted already distal perfusion cannula, but because of the low flow, because distal perfusion cannula generally we use a 6th French or 7th French, and the blood flow will be somewhere around 100 ml per minute. So it get blocked because of this. And the second complications occurs like hemorrhage. We come down on the heparin dosage. So there are chances of a blockage of your distal perfusion cannula. So all these three circumstances will land up into your limb ischemia. So always remember few points is flush the distal perfusion cannula every 4th hourly. So if there are small amount of clot, there will be a dislodge from your distal perfusion cannula. Second thing is if you are running a ECPR program where you are hurriedly cannulating the patients. So if you have cannulated VA ECMO, in that cases, you put a femoral artery and femoral vein, and there was no time putting in distal perfusion cannula, that is fine. But don't waste times. 1 year, if you have initiated the ECMO, within 3 hours, up to 6 hours, it is a permissible, but use the 3 hour times, put a distal perfusion cannula later on. You can use the PTA or ATA while doing cannulations. This artery can be used. Use a semi-stenical technique or open technique to perfuse the distal limbs. Otherwise, you will end up with another complications. And if you are not timely treated the limb ischemia, if it is a gangrene inside your limb, then there is mess. Then forget about the ECMO. So I'm not going to discuss about what are the clinical findings of the limb ischemia. We all are aware about it. Okay, management, always distal perfusion cannula has to be there in VV ECMO run. Maintain at least not 100 ml, but 150 ml per minute of flow. Flush the cannula, flush the distal perfusion line every 4th hourly. Limb elevations, and if you come across of tightening of your calf muscles, use a surgical consultation. You can use put a nick over that area, so your distal perfusions can be improved because of the microcirculations. Last but not least is a cardiac stunning. I'm not going to discuss its details because tomorrow Dr. Oja sir will tell you about details of cardiac stunning. But what is cardiac stunning? It is nothing but complete or near complete absence of ventricular contractions which lead to a cardiac stunning. So inability of heart to eject of antegrade against the excessive augmentations after load. Okay, it is a reversible conditions if you are treated it timely. Not all the cases will require a venting or surgical procedure, so don't afraid of it. If you do it timely management, if you detect it early, there is a reversible condition. So always try to keep a pulse pressures of around 10. Don't try to on peripheral ECMO, don't try to keep and the complete ECMO flow runs to high flow. So again, there will be less chances of cardiac stunning. So it generally cardiac stunning occur in initial days, not at later stage. So if you timely treated it, there are reversible factors. So what are the causative agents? Of course, afterload failure that will lead to your cardiac stunning. Electrolytes disbalance. Always try to correct a hyperkalemia, hypocalcemia, and acidosis. If you will not treat it, you will end up with another complications. Try to keep a target of lactate level below 3 to 4. So it will improve your coronary perfusions. There will be less chances of your cardiac stunning. Improve coronary hypoxia while increasing the ventilatory settings. Severe pulmonary hypertension also secondary lead to your cardiac stunning also. So what are the effect on the systemic effect because of the cardiac stunning is increasing LA pressures. There will be a pulmonedemia. Once there is a dictum, if you see the frothy secretions are coming from your ET tubes, there are certain institutes start venting at this stage because that is a nightmare. If you don't treat it, you will not able to win such patients from the VA ECMO supports. And because of this continuous increasing afterload, so there will be a aortic valve closure, and secondly it will lead to a mitral regurgitations, and there will be a constant stagnant flow in your LV which can lead to a LV thrombus. Again, it is a nightmare, and ventricular arrhythmia are going to be there because of the cardiac stunnings. So beautiful flow charts of how to treat a cardiac stunning, that's already given in the textbook. I am exceeding the time, so I'm not going to discuss in details about it. But try to first treat the medical management. Don't try to jump on the surgical interventions, but if it's needed, we can do a surgical interventions like LA venting or LV venting. It is not an contraindication. So I'm repeating it. There are certain institutes which see a these secretions from ET tube. They start putting LV or LA ventings to win such patients from the ECMO. Otherwise, you will not able to win a patients because of the cardiac stunning. So what are the take-home messages? It is not only for the ECMO. This take-home message is for all your sick patients which we treat routinely in our ICUs. Meticulous bedside examinations and observations is very, very important point. Early recognitions. So think before the disease will give you a good guide. Fine tuning between the team members. If somebody is studying to stop the heparin, discuss with your colleagues. If somebody is trying to put in another cannula, don't jump on putting in another drainage or the return cannula. Try to manage it conservatively as far as is possible. Immediate do extensive workup. Don't waste time in doing an extensive workup and management it. Do root cause analysis. So you do a primary workup, primary management, do root cause analysis and try to root cause. If you don't try identify to root cause analysis, sooner or later again these complications will occur to you. And proper counselings, because it is very important. Otherwise there are lot many cases of litigations nowadays we come across. So that is all about it. Thank you.